Good evening, everyone, and welcome to the 17th Plain Film and CT webinar. My name is Danish, and I'm the product specialist at Collective Minds. Those of you who are new, Imran Lasker will be hosting today's session. He has uploaded cases to the global community in a collection, which will be accessible to all of you guys that have now got a login and a user for the Collective Minds platform. We will also be recording this webinar, so it'll be available on YouTube for you to access later on. There'll also be a small feedback form at the end of this, which I'll post in the chat box. Please do fill this in. Once that's filled in, we'll be able to generate a CPD certificate and send that out to you. If there's any issues, any questions, please use the chat box below and we'll get on that. If you need any other support, email support@cmrad.com. and we'll be able to help you out. And yeah, with no further ado, we'll hand it over to Imran.
So hi everyone, hope everyone is well. My name is Dr. Lasker. Thank you so much for joining us today on this this talk. Got quite a few people turning up, so it's always very encouraging that people are still interested and hopefully going to learn something altogether. So I'm going to open up the chat function, and so that I'll be able to kind of keep tabs of what people are asking, and I will also keep the Q&A in case people want to ask any separate questions. And in the meantime, I'll also, I think we're going to give you the link to the actual cases. So apologies if it doesn't load up straight away. I do understand there's been a couple of technical issues, but in the meantime, I'm just going to go through the cases off my computer, and hopefully we will still be able to learn a few things together. So what I'll do now is just share my desktop, and let's open up this case here. So hopefully it opens up across. No, let's go. That's a bit too soon. Let's go for something not too difficult straight away. Okay, so what we'll do is open up this one. Okay, so we're looking at this CT scan, okay? And what I'll do one scroll through, because obviously I do understand that not everyone has access to the cases right now, and just see what you think is going on. And what we'll try and do is just write in the chat description what you think is happening. I'll try and answer them as best I can. So this is clearly a CT scan of an adult patient, and we can see that this is a contrast enhanced study because there's a fair bit of there's some contrast sitting over here that looks very, very bright and white. So that must mean that we're kind of what looks like an arterial phase, but also we've got a bit of contrast sitting within the pulmonary vessels as well. So therefore, this would kind of, sometimes you get like a combination of the two. It's not because we've done a dual phase, it's just the luck of the draw. So on first impression, we can see that there is what looks like bilateral pleural effusions, right? Quite large bilateral pleural effusions. And at first you think that, oh, maybe there's a pericardial effusion that is sitting over here. And actually there is some fluid around there, but it doesn't look like it's quite within the region of the pericardium, because you can still see there's a little bit of fat between there. So I'm not sure it's within the pericardium. It might actually just be fluid associated with the mediastinum. So you think, okay, great. You got some fluid that's in the mediastinum, not a big deal. Now let's go to the lung windows, and we can see that there is what looks like a lot of breathing artifact. And for those that don't know what breathing artifact looks like, it's where you can't really see the entire continuation of the vessels all the way through. They kind of look like little swans, as it were, rather than like straight vessels like that. And that usually happens because the patient's very, very breathless, and they have been able to hold their breath and the lung hasn't stayed still. And you kind of get this sort of fluttering appearance to the lungs. And you can see in these regions over here, can you see these all look like seagulls, kind of, they're not quite that sort of linear straight appearance that you'd otherwise get. But okay, so now when you come down to this area, we can see here that there looks like some collapse of the lungs. So there's a lot of fluid and it's kind of causing the lungs to sort of collapse in on itself. And then you can see maybe some air bronchograms within there. And for those that don't know what that is, I'll explain that to you guys in just a second. But it basically is consolidation. So this whole thing's kind of collapsed on itself. And that can happen because of the pressure, because of the pleural effusion. So you'll see that very, very commonly when you've got large pleural effusions, and usually within lung bases, right? So the next thing to do is obviously just have a look at the upper abdominal organs just to make sure they're okay. And you can see this kind of bright linear thing that is sitting along this region over here, going all the way down into the stomach. And that is an NG tube. And it's quite important just to make sure it's adequately placed. And it's quite far down, actually. It looks like it's right in the region of the pylorus. So generally speaking, you'd want it to be a region in the fundus of the stomach or in the region of the greater curvature rather than all the way down. So they might want to pull it back depending on the clinical symptoms. So if I go to this particular slice, is there anything that makes you particularly concerned about what's happening here at all? If you do find anything that you'd be concerned about, then do throw it in. If not, don't worry. I'm going to quickly talk about something else in the meantime. So hopefully this works. I have got a fancy new piece of equipment where I'm going to try and illustrate to you guys what is happening when you're looking at lungs on CT. So first off, you've got like your airways, which look like this, right? And can you just let me know if people can't see the pictures I'm drawing? So you got your kind of airways that go like this, and they almost sit like within the sort of cylindrical area, right? So let's say that's the airways, right? That's that's basically like a straw. And then around it, you're going to have like the container where all the air goes and it kind of dissipates around and stuff like that, right? Then this glass is essentially made of blood vessels and lymph. And you've also got an accompanying blood vessel going along like this as well. So when you've got a lot of fluid, right, what ends up happening is that it's just like having a cup of water where the straw doesn't get full. So that's what you'd have when you've got consolidation, right? So consolidation would be this cup full of water, but the airway is actually maintained all the way along. But then if it becomes cloudy, rather than being actually fluid filled, then it's going to be like dot, 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 like this. And that's where you get these ground glass appearances, right? So then what ends up happening is that when you've got this big consolidated changes, you can see the air bronchogram. And that's what we're seeing on that very sort of basal image, right? So now when we go back to the CT scan, a few people have said right side pleural thickening with associated moderate pleural effusion. So people have said that there's fluid pleural thickening, which is not a bad shout. I assume you're talking about, well, I guess it's going to be this area over here, yeah? So you may have noticed that, some of you may notice anyway, that there is a bit of a difference between the density of this area compared to this density over here. This looks slightly lower density and this looks slightly higher density. And actually it looks like it's tracking along the oblique fissure and all the way down. And there's a very definite difference between the densities of the fluid that is located within that hemithorax. If we look at the other side, you can almost see that, yeah, there is a difference between this area over here and this area over here. This area looks a bit more hyper dense compared to this area over here, which doesn't look as dense, right? So therefore, you've got to start being a bit concerned. There's more to this story than just a pleural effusion. Now, it's something to be aware of is sometimes you can have some artifact from maybe the arms being up. Sometimes the arms are being put right across here, and that can result in anything immediately behind the arms looking a little bit more hyper dense than they should. But this is very, very far away from the arms. It's almost uniformly hyper dense all the way down. So yes, it could be. It could very well be some soft tissue thickening, right? It does look a little bit lobulated. But the other thing is that in the context, if it's something like trauma, then you've got to be a bit concerned that this could be underlying hemorrhage. And so therefore the clinical history to be I don't know how I muted myself, so I'm going to start again. So the thing is, you've got hyperdense material that is located within this region. And so therefore, you've got to be concerned, is this soft tissue or is this sort of hyperdense fluid, i.e. blood, right? And then you've got to really start looking around, seeing if you can see any rib fractures or anything like that. And I can't see any rib fractures, but you can see that the mediastinum has had a previous sternotomy, but it doesn't look particularly like there's callus formation around. It looks like a very recent sort of procedure. So actually, this is most likely to be a recent procedure that has happened. And actually, when you look at the neck over here, can you see there and there is what looks like a line that's going right into the sort of SVC. So clearly this patient's unwell, most likely have had recent cardiac surgery, which is why you've got a lot of fluid located within the mediastinum. And actually, as you come further up, you can see there's multiple clips located associated with the mediastinum as well. And you've got this hyperdense material located within the pleura. So I thought this is an interesting case because it illustrates quite well how at first glance, when you go through, you think, pleural effusion, cardiogenic failure, big deal. But actually, when you look at it a bit closer, you can actually see, yeah, you know what, there is a difference between that density there and that density there. And that's where you've got to start being worried. Now, the big question is going to be, is this patient still bleeding? So you've got to scroll through and really try and make sure that you can't see any sort of bright blush located within that pleural area, because if there's that bright blush, then you're thinking that, okay, this could be an acute and ongoing bleed, but I don't think I can convincingly see that there is anything like that. Now, let's say you said that there's a big hematoma located within that region. You haven't seen any active bleeding or anything like that, but the patient's still quite unwell. So the other thing to do is just make sure that you've had a look at everything else to make sure there's no other area that the patient could be hosting blood from. But you may end up just having to go to the interventional radiologist, who will then have to basically live inject some contrast into the patient, see if they can identify any potential points of bleeding. I don't think on the CT scan you can be so sure that there's any point of bleeding there. Right, so yeah, well done, everyone. I think people have done quite well with that one. So let's open this case and have a look and see what's going on. So it's going to be quite a chest-heavy case, a lot of cases today. So having a look at this case, we've got, it looks like an X-ray of an adult patient, and it's very, very important to make sure you've had a good look at all the lines. So we can see that there's a line going down like so, all the way like so, and that looks like the NG tube is actually adequately placed. You've got your central line that goes all the way down like so as well, and that looks like it's adequately placed as well. So okay, lines look okay. I'm not particularly worried. Do they have an ET tube? Yeah, I think they do. So they look like they might have an ET tube which stops here, and you'd expect the bifurcation of the carina to be over here. So that's also adequately placed as well. If that ET tube had gone all the way down like so, then you'd be worried. Then you'd probably see some sort of collapse or some consolidation or hyperinflation, depending on what they're actually doing with the patient and that tube at that particular time. But on this patient, I think we don't see anything like that. I think all the tubes are adequately placed. We're not worried. But then with this patient, you can see the sort of kind of almost like net-like, you know, thickening all the way through, right? All the way through both hemithoraces, no particular, you know, distribution, no perihilar distribution per se, and almost uniform across. Exactly, someone has said it correctly. At this point, I think, depending on the clinical history, but at the very least, you can say this is most likely to be in keeping with pulmonary edema. Now, when we go back to my little diagram, what you'll notice when you're looking at these, oh, sorry, I've used the wrong pen, I've used the Apple pen. So when you're looking at CT scan from above, each kind of air cell looks like a little hexagon like this. And you've got this little dot for your blood vessel, and you've got a little dot for your airway as well. And so what can happen is that when you can actually get thickening of the surrounding hexagon, basically. And that's going to be as a result of a few things, right? So either it's going to be lots of fluid, it could be lymph that's done it. And I mean, it's not really going to be blood, but it can be lymph. And also and then that's when you've got to look at it. Is it smooth thickening or is it kind of nodular thickening? So if it's nodular thickening, we get lots of nodules along there, then you're probably thinking along the lines of carcinomatosis, lymphangiomatosis, or you're thinking something along the sarcoidosis, because that causes a bit of lymphadenopathy as well. In this case, what I think we're seeing is sort of very smooth interlobular septal thickening. I know it can be difficult to see that or say that 100% on a CT scan, but generally speaking, it doesn't look like there's very much nodules anywhere. It doesn't, and when you look at that sort of interstitial, sort of that fissure over here, that doesn't look particularly nodular either. So I would actually go towards sort of a cardiogenic failure, exactly like someone said, pulmonary interstitial edema, something along those lines, or ARDS, depending on the clinical history. Something that would actually favor something like ARDS is clearly the patient's quite unwell, very, very unwell, right? Heart doesn't look particularly large. So this is maybe something that's happened quite recently, quite quickly in the middle of being generally unwell. So I think this is I thought was quite an interesting picture, just because I had that sort of very net-like appearance. So when I do a lot of the teaching for people, I often tell them, you know, they'll throw in something like reticular, but I don't think they know what they're really saying when they're saying reticular. So reticular essentially means net-like. So if it looks like a net, you can say reticular. But then if you say reticular nodular, that's when you're talking about those little tiny nodules that I was talking about earlier, where then you're going down very specific roles of, is it sarcoidosis? Is it basically cancer, underlying cancer within the lymph system? So yeah, that's hopefully a fairly interesting case. Now this one I think can be a bit of a challenge for people. Do throw in what you think it is, and in the meantime I'll talk my way through it as well, so that we can sort of work through it, because I want you guys, you know, anyone who comes to this, be able to sort of work through the problem rather than me just give you the answers, because I don't think giving the answers is the way forward when it comes to teaching. And for those of you that have come to my teaching, hopefully you walk away thinking not only Do I know the answer? I know how I can get myself to that answer. So no answers coming in just yet. So okay, so what have we got here? We've got a adult patient. Okay, and we can see nothing grossly abnormal in the beginning. So I've always got these check areas. For those that don't know, they can be the lung apices. I always look at the costophrenic angles as well. And then I also, then I'll also have a look at the heart as well, just to make sure there's nothing behind the heart. So there's nothing behind the heart from what I can see. If anyone can see anything, do let me know. So someone said bilateral axillary masses. So that's a very interesting thing to think about. Sorry, that's not me giving a laughing emoji. I am taking you seriously. So you're thinking around these areas and these areas, right? It's not a bad shout. I mean, I would say maybe, possibly, but you have to also understand that, people can have skin folds. I think that's a pretty decent way to say it. So you can have skin folds. It can be all sorts of things. So I wouldn't necessarily jump towards that, especially in the context of maybe something else going on. So then have a look at the mediastinum. I always look at the mediastinum just to make sure there's no secondary sort of film-like density along there, because I have seen it where it can be very, very thin, and that's going to be something like pneumomediastinum. So no pneumomediastinum from what I can see. And then, a few people have got it. That's good. So then also look at the ribs as well. Just make sure there's no obvious fracture. Now, I don't know if people do this, but I really do zoom in and look at the lateral aspects of the ribs, because sometimes the angle means that you just slightly miss that the rib fracture that can exist. And actually, sometimes it is worth sort of just spinning that the ribs around. And I don't know what it is, but maybe eyes are just better at looking at linear curves on a kind of superior to inferior basis or something, but that sometimes does help looking for abnormalities when it comes to the ribs. But here, I don't think we can see any rib problems, and the humeri look okay. Sometimes you get some avascular necrosis, can't see anything abnormal there. No fractures. Clavicles can sometimes be missing as well, and the lung apices are completely clear. But yeah, some people have pointed out, you also got to look under the hemidiaphragm. That's my final check area. Look under the hemidiaphragms, make sure there's nothing abnormal. On this situation, we don't have something called a continuous air diaphragm sign. So generally speaking, you shouldn't have an interface between the cardiophrenic angles and the diaphragm, because they're almost equal in density. And if there is an increased contrast or fluid and air between the two areas, then you're probably looking at pneumomediastinum. We don't have anything like that here. We don't have a continuous diaphragm sign, but as people have pointed out, there's a little tiny slit of air. Can everyone see that? If you just point in there, can you see that? Tiny slit of air just sitting on top of the liver. And so straight away, you've got to be thinking, yeah, this could be air under the hemidiaphragms. Yes, someone has said that it could be a normal post-operative appearance. Any sort of air within the abdomen could be a post-operative appearance, depending on when the operation was done. But if got someone who's come in and they've not had any surgery and they look like this, then you've got to be concerned there's some sort of gas-forming problem here. So either it could be a perforated intra-abdominal viscus, i.e. bowel, or it could be a gas-forming organism. And I've seen this kind of thing happen with emphysematous pyelonephritis, emphysematous cystitis, abscess formations that happen as a result of a perforated diverticulum and all that kind of thing. So yeah, it can be post-operative, but that's why the clinical history is so important with all of these kind of these situations. Right, so let's have a look at this one and see what people think. So I'm just gonna, so yeah, please feel free to throw in your answers. Tell me what you think is going on. And what do we think? What do we think? So this is an adult patient. I think they look like they're slightly rotated, don't they? So for those that don't know, what you do is you look at the medial ends of the clavicle and make sure they are completely aligned with one another in terms of with regards to the spinous process. And the spinous process should really be sitting right down the middle. But actually, we don't have that. We actually see that spinous process is there, and we're slightly closer to this medial aspect of the clavicle. So they're kind of slightly rotated. So with this one, we do actually have a question to come up. So what do we think this is? What do we think is happening here? So I said, which one of these do not cause these appearances? So people are putting in their answers. I'll look at those answers in just a minute and while we work through. So I assume people have noticed that there is something clearly quite abnormal with regards to the mediastinum. Someone has said a bronchogenic nodule. I mean, that's not a terrible shout, but actually there are multiple other nodules or lesions scattered throughout the mediastinum. I'm going to point those out for you there. So there's one there. You feel like there could be some increased density somewhere along here as well. Maybe some increased density along here, but yeah, this is the most obvious one that we can see. Definitely here, right? Calcified lesion in the mediastinum. So what caused that? So rheumatoid arthritis doesn't usually cause calcified lesions, right? It's actually would maybe cause cavitating lesions on some occasions, but not calcified. So the other ones can cause calcified lymph nodes, right? Sarcoid, silicosis, lymphoma, especially if it's treated lymphoma. So lymphoma doesn't initially cause calcified lymph nodes, but in these some situations it can, where you just got this calcified lymph nodes after treatment, right? So this looks like a single calcified lymph node. There's something else like Carson's disease, a bit of an odd disease. I can't remember what it's like. You can get this singular enlarged lymph node adjacent to the mediastinum or esophagus that can cause calcified lymph nodes. Interestingly, I remember reading that in the abdomen anyway, you can get calcified lymph nodes as a result of having non-pasteurized milk. I don't know how that would even happen in the first place, or why people even know that, but it's the thing, you know, genuinely, when you look around, you'll see people or see articles written about that kind of thing. But anyway, when you're looking at this X-ray, you can't see anything else really going on. They're not exactly a young patient. You can see that there is some significant osteoarthritis involved in both glenohumeral joints. See that little band there? That's a thin band of atelectasis, maybe a few more thin bands of atelectasis. Everything looks okay. So I would say this patient is in a rotated, slightly kind of bent over position, kyphotic position, and you've got this almost uniformly calcified lymph node located within the right mediastinum. Differential diagnosis would be, et cetera, et cetera, et cetera, like I was saying. Now, the thing is, it's really important to quantify that the patient is rotated, because I've too often seen people start worrying about this area over here. And you have to understand that as people get older anyway, you do get some very normal apical scarring on both sides, especially when the patient is slightly rotated. You're going to have that sort of abnormal looking appearance to the APC, something gets sort of overshadowing from the neck, the soft tissues of the neck, the chin. I've seen that kind of cause some shadowing, people calling that kind of thing. So just be aware that I always quantify the limitations of your study. If they're rotated, if they're kyphotic or anything like that, then just say that, because then you understand that, okay, there's going to be some limitations to your interpretation, right? And just for those that want a little bit of a bonus point, you can actually see there's a little bit of atherosclerosis sitting within that aortic knuckle as well, but no widening of the mediastinum per se. And I know someone said widening of the mediastinum, but you also have to remember, right, this patient's rotated, so you kind of seeing them at an angle anyway. Look where that airway is compared to the rest of the aorta over there. You're kind of seeing it at this kind of rotated position, which means that the mediastinum is naturally going to look a lot wider than it otherwise would. Right, so let's have a look at this case. So this one, I think, okay, so I've seen these answers. Yeah, well done. So a few people went for rheumatoid. I wouldn't really go for rheumatoid when it comes to calcified lymph nodes. I would go for the other ones when it comes to calcified lymph nodes, unless you were saying that because of what the shoulders look like. But with the shoulders, they didn't look like erosive changes. They look like loss of joint space. And for those that don't know this, there was an acronym, wasn't it? Let me just, the acronym was it LOSS, right? So it was loss of joint space, osteophytosis, subarticular sclerosis, and subarticular cystic change, something like that. So that would be osteoarthritis. And that's actually what we saw with the patient's shoulders, rather than there being anything else. So I don't think we could go for rheumatoid arthritis per se on that. Okay, so let's have a look at this one. Interstitial lung disease. Can you mention which case you're opening so we can follow ourselves? Yeah, I wish I could, but I think for me, I'll try right now, because there was a few issues going on with the platform itself, which is why I'm actually presenting it off my computer. I don't know if anyone from Collective Minds can give me an update. Let's see. So I'm going to try and open it. But in the meantime, if you do think you can see something, then do let me know. Okay, I might actually be back live. You can see the case. So what I'm going to do, I'm going to close down this bit, and I'm going to bring across this window here. Okay, so what we'll do now is go there. So yeah, it looks like it's working for me as well. And let's go back up. So we've done this one, this one, this one. So let's do case number 6. So this is case number 6. I've got to wait for it to download for myself. Yeah, so what do we think is going on here? So the thing is, like, yeah, you can throw all sorts of diagnoses down, right? But I think it's very, very important to just sort of describe what you see, and then sort of infer what you think you can see by, you can try and infer a conclusion, but I don't normally go for a slam dunk usually when it comes to this kind of thing. So what you do here is you zoom in here, and just have a good look around and see what you, yeah, and try and have a look and what's happening here. So here, oh, yeah, look, also my other pen's working now. So you can see the sort of these circular areas here. Can you see that, right? And then as you look, you can see the sort of kind of increased linear markings all the way around here, kind of peripherally based. And actually some of those circular areas look slightly more thickened than other places. And actually maybe a slight predominance for like the lower lobes and some of the sort of mid zones as well. The lung apices actually look like they're relatively well spared. So yeah, exactly right. People have been saying exactly what you need to be saying. It looks like increased coarse reticular changes scattered throughout both hemithoraces. And when you get sort of more thickened sort of appearances where they kind of look very, very circular next to each other, it almost looks like happy face, doesn't it? That's not what I'm trying to do, but it looks like an almost honeycomb appearance, something like Pooh Bear. My kids have been getting really into Winnie the Pooh recently. So it's like Pooh Bear would be interested in that, some of that honey that is sitting within that region over there. Now I'm going to go across to this area over here. I'm just going to try and explain, like, basically what's happening is that you got your airways, right? Oh, sorry, wrong pen. So you got your airways, which are like this, which we've kind of established, and then they're kind of and they kind of thinner and thinner as you go along. But you've got your lung architecture all around it. And so what can happen is that you can get sort of peribronchial wall thickening, but you can also get something called traction bronchiectasis, right? So bronchiectasis is where you get widening of the airways, and so they're just far too wide as you go further down. It usually should taper, taper, taper. So what's causing that, right, is because you've got loss of lung volume, and as a result of the loss of lung volume, you get sort of pulling of the actual airways along like this, and so therefore you get this sort of kind of irregular bronchiectasis, right? And therefore it's going to be traction bronchiectasis because these bits are getting pulled away. So very, very important to know that there are two different types, because there's also bronchiectasis where there is no sort of irregularity, but it's just very, very widened. And that can happen as a result of repeated infections, bronchiectasis. Yeah, exactly. So you get traction bronchia, someone's written here, traction airway dilatation. Yeah, so you get traction bronchiectasis, or you can get traction airway dilatation, or you can get sort of like a smooth dilatation as a result of repeated infections and things like that. So there is a bit of a difference. So with this particular X-ray, you'll be looking at sort of a traction dilatation of the airways rather than a smooth dilatation, because you can see that there's clearly some sort of like airway thickening and some dilatation. It looks kind of a bit more too sort of spherical and around the sort of more peripheral aspects of the lungs there. So we are looking at case number six, in case you're wondering. But now I'm going to go to case number 7. So let's open case number 7 and see what's happening here. So thankfully, platform's working quite nicely. What do we think is going on here? So, okay, fine, yeah. So then when we are looking at this particular X-ray, we can see that this patient has got a, yeah, what's going on here? So we have got they don't look particularly old, do they? And so, but we can see that there is a sort of linear density located within this region over here, right? It looks like maybe could be consolidation. Yeah, so let's have a look and zoom in and just see whether we can see consolidation, right? So is there consolidation? I don't think there really is. I mean, there are some linear densities located within this region over here, but otherwise it looks okay. But there's actually what looks like blunting of the acrostophrenic angle over there, right? So that's one thing. So there's a small pleural effusion. And then also what we can see is, yeah, exactly right. So someone said that there is what looks like a linear density that's going along like this. So straight lines like that should not exist. They just should not exist in the human body. Not when they're so linear, like either someone's put something in, or what you're looking at is essentially what you're saying. It is a fluid level, right? And because the patient's standing up when they're doing this X-ray, you've got a fluid level like this. So people are saying all the right things. So could it be, so what you can have happen is that you can have underlying lung disease, i.e. emphysema, where you get very dilated airways, and sometimes you get big bully, right? And sometimes these bully can be really, really large, and then you get sort of infected bully, and that can result in this fluid formation. Otherwise, it could be an abscess. Yeah, it could be an abscess. It could be an abscess sitting right here, and it could be an empyema. Well, empyema, less likely because it's so circular, but yes, it could be, because sometimes you can get sort of yeah, you could get some fluid located in the pleura and the posterior aspect like this. Yeah. So that is possible as well. And I guess you might be saying that because you're thinking that there is a blunting of the acrostophrenic angle, which may go along that line. Actually, it was an infected bully. So this patient, as people have said correctly, I've noticed that this patient's clearly got a long-term underlying lung issue, essentially. Okay, so let's have a look at this case. And so let's put that across there, wait for that to download. Okay, so we are, it's not downloaded. Okay, so here we go. So we have got this patient here, and this is, they don't look particularly old, I guess, but straight away we can see there are a few abnormalities that are quite striking. We'll work through it together. So we can see around this area over here, this looks slightly blunted, and that area looks slightly blunted as well. So we're looking at bilateral pleural effusions, right? And then you can also see that there is a sort of increased sort of densities within this region, but actually looks very, very spared around these areas. And when you look at the highlight over here, but then they kind of look a little bit too high, or high highlight, as they were. So that's when you've got to start worrying about, okay, what's going on here? What's happening? So it looks like increased density over here. The highlight looks like they're slightly increased here. You've got bilateral kind of pleural effusion, sort of linear reticular changes around the rest of the lungs. So someone has said, that's really good, AT shop. Yeah, I was trying to look up what that is. So for people that don't know, someone has said AT shop. And AT shop is actually an acronym, which is for upper lobe fibrosis, right? And basically, this is upper lobe fibrosis, and therefore you've got your diagnosis for upper lobe fibrosis, which is going to be, well, I can't remember. You know what? I think let me just open up. But yeah, tuberculosis can be one of them. Extrinsic allergic alveolitis, ankylosing spondylitis, sarcoid, obviously histiocytosis. There's loads of things. So I wouldn't go for a slam dunk with, oh, I know what it is, unless you've got multiple calcified lymph nodes. Then you could maybe go for something like sarcoid or something. We don't have multiple calcified lymph nodes, but we do have clear sort of biapical fibrosis, loss of lung volume, maybe some tenting of the hemidiaphragms here as well. So I would definitely go for, I would say, if I was reporting this, I'd say this is an adult patient. I can see that there's increased density in both lung apices with tethering of lung parenchyma towards the lung apices, and the high look elevated. There's also tethering of the hemidiaphragm, blunting of the costophrenic angles. I'd be concerned for apical fibrosis. Differential for this would be, et cetera, et cetera, et cetera. Can this be lymphangitis? So lymphangitis, I guess over a long period of time it could, but generally speaking, when anything's lymph, it wouldn't really be sort of so focused towards the lung apices per se, but I wouldn't quote me on that because I don't actually do, I'm not really a lung radiologist, more of a general kind of person. Okay, so let's open the next case. Very, very chest heavy today. I was actually telling someone, like, I wasn't trying to, sorry to confuse, I was meant that we're moving away from BTS cycle, traction, bronchitis, okay, fine, yeah, I don't mind, I'm actually here to learn as well from you guys, so this is actually useful for me. Okay, so we've done this one. Oh yes, because we were using my hard drive to do some of these cases, so we can leave that one. This is the perforation for anyone that doesn't remember. I know we were kind of jumping between cases, so I'm going to just go back to case number 1 here, because I don't think we did this one because I wasn't able to log into the platform earlier. So case number 1, if we want to go back, tell me, oh, sorry, that's, is anyone else on Duolingo? I'm on Duolingo, and early bird chest available. How appropriate. Trying to learn Spanish for anyone that might want to teach me Spanish. I find it quite difficult. Okay, so let's have a look at the skull X-ray. And so what you do, I mean, you've got 2 views here, right? You've got your sort of more sort of direct view, and you've also got your OM view. And actually, generally speaking, I do sort of just jump straight to this one and try and glean as much information as I can. So when you zoom into this, what I would say, I don't know if you guys can see this, and I always find this quite a useful thing to do, is have a look at the soft tissue here. Can you see that soft tissue there? Okay, so I'll go through number 2 as well. So you can see the soft tissue there. And actually here, can you see that looks a little bit sort of bigger, doesn't it? It looks like there's some inflammation located within that region, right? And so someone might say, oh, is it mucosal thickening? The thing is, look, this person's got very, very big soft tissue swelling. And I wouldn't really, mucosal thickening would be within the axilla rather than within the region. Or someone said within the, are they saying, so let's have a look. They said mucosal thickening within the frontal sinuses. Is that right? Frontal sinuses are over here, and over here, and they look pretty good. Let's go to this one and see whether we can see any definite mucosal thickening. I wouldn't really bank on it, really, personally. But what I can bank on is the fact that this patient's got quite increased soft tissue density over here, right? Quite unusual, because normally so this is the right side, and that's the left side. So normally when someone gets an injury or get punched in the face, they get punched on the left side because someone is normally right-sided when they're getting punched right-handed. But this is left-sided, so I'm speculating. I'm not saying they were in a fight, allegedly, maybe not. But you've got to look at now. So this is where you got to start focusing, like what could be going on here. So then when you go back to the sort of more AP view, one of the things to do is to have a look at these areas over here. Just make sure there's no obvious air located within the orbital region. So someone said it right there. There is some periorbital soft tissue swelling. And actually now when you look on this view, this area just looks far more dense than that side, doesn't it? It just looks much more dense. And then you've got to start looking at your sort of more typical areas for where you'd get injuries. And the way to do that, in my humble opinion, is to draw along the inferior orbital wall, see if you can see any obvious abnormalities. I can't say that I can 100% say that. Lateral sinus wall looks okay. And then you've got to go for this sort of elephant. So a lot of people talk about the elephant. Elephant trunk is over here. Elephant trunk is over here. So on here, it looks slightly weird to me. So then it's better to go across to this view. Let's zoom in and see what's going on. And actually, it doesn't look quite right. Can you see that? That looks a bit funny there. That looks a bit dodgy there. It doesn't look like it's quite lining up. So I would have thought that this person's got a left zygomatic arch fracture. So very, very important. If you see that, you've got to look for this one and this one, because then you'd be looking at a tripod fracture. But I don't think we can say that as a tripod fracture. The maxillary sinus doesn't look like it's particularly opacified. So we're not looking at an orbital floor fracture where that would be like, when you get a trap door and it just opens up like this, like boop, and then like a whole lot of orbital fat comes through it. I don't know. Does anyone watch boxing these days? There's like Kell Brook back in the day. He got fractured on both orbits actually. On two separate occasions, two separate fights, and he had to put some metal along the bottom of there. Okay, so someone said, I need to look at case number 2 because I haven't gone through it. So try and open case number 2. Let me know if I have gone through it already. No, we haven't. Okay, so let's have a look at this one. So they don't look particularly old. So when you look at this one, do fill out the cases, the little questionnaire. See what you think. Have you seen anything? If you've seen anything, where is it? Where is it? Where do you think it is? So we'll do, I'm going to try and show you how to work it out. As always, I don't want to just give you the answers because that's not very fun. So I always look at the lung apices straight away, make sure that they're okay. And they actually look all right, don't they? They don't look like there's anything going on there. Look at the costophrenic angles. They look very, very normal as well. Then I want to look behind the heart and make sure that's okay. And check the mediastinum, really closely look and see if there's no second line there. That looks okay. Under the hemidiaphragm looks okay as well. Sometimes you get a bit of a breast shadow sitting along this region here. So don't fall for that. Don't call it perforation or anything like that, yeah? So now we have to then look at the bones and really just have a look at the edges. So really look at the edges, make sure there's no evidence of any fractures, which I can't see. I can't see any fractures anywhere. But actually, when you get to about this region, you've got to start worrying that there is something around there. So I don't know if anyone can see that. Let's zoom in. There looks like there is some soft tissue or some sort of increased density located within that area over there. You've got to try and look and see whether you can convince yourself that there could be a linear density or linear radiolucency over there. There may very well be. It could be a rib-based lesion, but it's very, very well defined. The more you look into it, the more you zoom in, it looks very well defined. It doesn't look like there's much space between the chest wall and this lesion. So I would have actually gone for a pleural-based lesion just because it looks like it kind of has a sort of obtuse angle like this. That's what it looks like to me. But I mean, you'd have to do a CT scan really to be 100%. In reality, I would definitely play this safe and say that, you know what, there's this well-defined opacity. I would measure it, say predominantly within the lateral upper chest wall. I'd be concerned that this could be a lesion. It could be pleural-based, recommend a CT scan. And obviously, whenever you get anything that you could, you're worried that could be an underlying malignancy, very, very important to make sure that if there are any potential metastatic foci is worth looking for. So yeah, a few people have gone for it, mediastinum. I was more interested, I'm not saying the right or wrong answer, I was more interested in what people's gut feelings are. And people have gone for the lung parenchyma. Interesting, because normally I would go for lung parenchyma if it looked a little bit more acute in the sort of on this kind of corner here. And if it's more acute, then it's less likely to be coming from the pleura. And if it's kind of obtuse and sort of very kind of flattened coming out, then I'd be thinking more of the lines of a pleural-based lesion. But anyway, I think it's one of those things that can be missed. And I think using the check areas that I'm trying to sort of give to you guys whenever you're looking at any X-ray. Hopefully, you can pick the stuff up, like, and people think that you're a hero. You're all heroes. You're spending your time with me, so of course you're already a hero. So anyway, okay, fine. So now let's look at this case number 10. I'm going to wait for that to download. And this was someone who came in with abdominal pain. And it looks like we're probably looking at a porta venous image, aren't we? Most likely. Yeah, so I'm just waiting for that red line to come across. I guess I can just sort of start scrolling from the top. So it looks like a contrast enhanced study. Let me know what you think of this CT scan once it loads up for you. So for those that don't know, we are on case. Oh, so someone's raised a hand. Is that because you've got a question? Someone raised a hand because they've got a question. If you've got a question, yeah, go for it. If not, that's fine. I'm going to carry on. I'll let Danish see if you've got any questions. So, okay, let's scroll through this CT scan. We'll go from the very, very top all the way down, all the way down, all the way down. So this looks like it's a porta venous image coming all the way down. Oh, someone's talking? No. Okay, so what have we seen so far? Yeah, so someone's saying, yeah, good. So then what if if someone's coming with abdominal pain, we've got to start thinking along the lines of what could this be? So let's scroll through. What can happen with that abnormality that you're talking about? So one of the challenges I've always found when it comes to what we're looking at here, so someone's already pointed out, I'm just going to go for it because the rest of it is not quite uploading just yet. But as you kind of come to the top of the image, some people may not spot straight away that this aorta does not look normal at all, right? So if we see here, if you keep your eyes down there, scroll down, you can actually see there's like a linear density, like a linear difference between this area and this area over here. And so as you scroll down further, you can see that this kind of curves around this way, keeps going, curves around that way, curves around that way. And then it sort of communicates with that area there. And then that communicates that way. This communicates that way. And there's almost like two different lumens that are communicating with different parts, with different parts of the body, right? And so, yeah, everyone's right. There is an aortic dissection. So the next challenge is trying to think about what is the true lumen and what is the false lumen. So generally speaking, not hard, fast rule per se, but the one that's slightly more dense is usually going to be the true lumen, because that's where you get the least resistance when it comes to flow. And the one that's got more resistance is going to be the false lumen. So that is, I don't know, if you look at the blood vessel like this, you got your blood vessel wall, you got your blood flowing through, and then sometimes a weakness here can result in a sort of like a different pathway for the blood to go. So instead of going down the normal lumen like so, it ends up going along the wall and stripping it. And you can imagine that that's not going to be the easiest way to go, right? You'd rather go down the normal lumen, but what ends up happening is get stuck down there and keeps going through into the, and it may actually start dissecting further and further. It's dangerous because obviously it can result in a cascade reaction, can result in ischemia, obviously very painful because essentially aorta is ripping from the inside of you, which is a horrendous appearance, horrendous thing to think of. And also what ends up happening is that you get this sort of what can be like little cobweb appearances, right? Little tiny cobweb appearances, because that's kind of clot trying to form. And actually, usually you find that the one that's kind of more circular and less crescenteric is more likely to be the aortic dissection. So the thing to worry about is when you've got sort of false lumen communicating with the large vessels, because then you've got to start worrying whether, true blood is going to get all the way through to the rest of the organs. And actually in this particular situation, we can see that the kidneys are actually enhancing pretty normally, and the bowel doesn't look too bad either. So if we go back, very, very important to make sure that you don't have underlying ischemic bowel, because if you've got dissection, you can get thrombosis. Thrombosis can result in lack of blood flow getting into the bowel, and the bowel can die, and et cetera, and it becomes a big cascade of problems. Aortic problem leads to blood flow problem, which then leads to blood supply problem, which then leads to ischemia, perforations, and all that stuff as well. So what I always do as well, just to be 100% sure, is have a good look at the bowel. I follow all the way around. You can see my mouse is, we're going all the way here. So these are the constants. I always say the descending colon is a constant, come all the way across to the transverse colon, all the way across, and actually the bowel looks okay so far. Coming down to this area over here where the cecal pole, everything looks okay. And then I keep a sort of cursory eye down the middle of the abdomen just to make sure the small bowel doesn't look particularly inflamed either. So I know that part of the body is missing there. And then bonus points, I guess not particularly important, I guess, with this particular patient. They do have a periumbilical hernia, and they've got inguinal hernias located in both over here, right, as well. Can you see that? So the little inguinal hernia on the left, which contains some fat. Generalized subcutaneous edema as well, which is pretty much unrelated to the overall picture of the patient. So yeah, exactly right. We've got a patient who's got aortic dissection. Now you can imagine that someone like this turns up with abdominal pain, and you may miss that. And the reason why you may miss that is because this is not a dedicated. Usually the false lumen would be smaller. Actually, there's a really good checklist. I won't be able to find the checklist right now, but if you type in aortic dissection checklist, there's like literally a really good checklist looking for how you can tell the difference between a true lumen and a false lumen. In reality, if you're reporting, right, especially if you're a registrar or anything like that, the biggest thing you just got to say is what type of dissection it is. Look for secondary findings. Is it ischemia? Is there thrombosis? And all that kind of stuff. Vascular referral done. Yeah, and then they will end up talking to the vascular surgeons, the interventional radiologists, and all that kind of thing. So I think you can actually keep it fairly simple when you're a general radiologist reporting something like this. The reason I brought this up is because at first glance, you think abdo-pelvis, and if you don't have the vessels as your check area, you may walk away thinking, yeah, abdo-pelvis normal, no abnormalities, no perforation, no ischemia, et cetera. But that just being able to just sort of have a look at the aorta, or even doing the thing where it's also doing the thing where you actually have a look at the aorta to try and decide what phase of imaging that you're at. That can also help you. The other thing that can help sometimes is you get atherosclerosis with the aorta. So sometimes the atherosclerosis will kind of be pulled inwards. And so you'll see this sort of calcification linear bit. And then on the outside of that, you see some contrast. So therefore you'll be able to say that, okay, anything sort of inner to that calcific sort of density on the outside is going to be normal lumen. And anything outside of that is going to be false lumen. That's another way to try and identify which one is which. So those are some pretty decent signs to look for when you're doing that. Okay, so let's have a look at, so when it says, is the false lumen always smaller? Not always, it's not always smaller, but just most of the time. Okay, let's have a look at this one. We've got a chest x-ray, and we are coming up to time. Okay, so we are, I think we've got time for this one, right? I think so. So we've got a chest x-ray, and look, I mean, let's see what you guys think. See what you think. Okay, yeah, good. So someone's saying false lumen due to larger to high pressure. Okay, fine. So someone's saying that actually the false lumen is usually larger due to high pressure. Okay, fine. Okay, so then, let's have a look at this X-ray and we'll see what we think. Okay, so false lumen is usually larger. So I think we unanimously were saying false lumen is usually larger. Cobweb sign, I think that's true. And the atherosclerosis and all that kind of thing should be true as well. Anyway, it's quite an interesting case, I thought, just because I think it's a good thing to try and look for when you're looking at abdo-pelvis, because sometimes, you can miss that. Okay, so now let's have a look at this case. And we've got, a few people have said a few things here. So let's have a look. So both lungs look actually okay. And actually quite a young patient, aren't they? So you can see that they've got growth plates here. And what we do is have a look at the check area. So lung apices look okay, costophrenic angles look okay, and behind the heart looks okay. And then what you want to do is just check along the mediastinum. And actually, can you see there's a linear radiolucency that goes all the way along like so, like a line that goes all the way along like so, right? So therefore, and then someone said, is there a continuous diaphragm sign? Yeah, I think so. Can you see that? Like the other ones, we said there was no interface between the cardiophrenic border and the hemidiaphragms. And this particular one, we feel like there could be, yeah? So now, and then actually when you come up to the apices over here, in the supraclavicular area, can you see there's radiolucency sitting all the way over there as well? So therefore, this would be in keeping with pneuma mediastinum. And actually, thankfully, someone has donated the rest of the case, and we'll put the little cloud button to try and make it a bit smoother. And yeah, so can you see here straight away, corresponding to what we saw in the X-ray, and got evidence of pneuma mediastinum. Now, yeah, mission. Okay, so then that can happen because of vomiting, trauma, that kind of thing can cause pneuma mediastinum. Actually, not much in the way of air under the hemidiaphragms, but definitely can you see all around that cardiac border, around the anterior mediastinum. Actually, there's some air located within the axilla over here as well. So yeah, extensive subcutaneous edema, air. There's air within the fascial planes between the musculature of the supraclavicular structures, and there's also air located within the pneumomediastinum as well. Okay, so I think that is the final case that I have. So yeah, apologies. And so that is the final case. So apologies in advance. We did have a few technical issues, which kind of threw me off a little bit, but I hope, as usual, that has been a useful exercise. I definitely learned a few things, and hopefully you get to see some interesting cases, some decent cases as well. Always thankful for so many people turning up. Big turnouts to these. And as always, do let me know how I could make things better, how I can give you guys value. Because I do want to make this as useful for you guys as possible, so that if you are on the wards, or even if you don't do radiology, I think radiology does affect us all. And also check out Collective Minds. I mean, they're the ones that are making this possible, the people that allowed me to do these talks. And I think it's a very good platform, and I'm very excited for the future that it has itself, because they're doing some really cool improvements as time goes on. So do sign up, do check it out. And as always, I'll see you on the next one. Bye.
Thank you very much, Imran. That was another great interactive webinar. Again, I just want to apologize for the technical difficulties earlier on. We have got everything up and running. I am just going to send the link for the feedback now. So if you just fill that in, as soon as that's filled in, we'll be able to get your CPD certificate out to you. And just to bear in mind that the collection is available on the Collective Minds homepage. So you can see it here. There's two ways of searching it. You can either just go into collections, and then you'll be able to just filter that to recently created, and there you will find the plain film and CT webinar 17. So that's a collection for today's cases. What you can also do is you can go onto this first case, which is currently on the homepage, and here you'll be able to access our previous collections for our previous webinars as well. So we started back in May, so all the collections that we've been going through are all available there. What you can also do is just give us some suggestions of any future topics, or maybe even some guests that you would like to see on future webinars. You know, it'll really help us out to keep things interesting. So if you do have any suggestions, just use the reply button here, and you can just give us a reply on there. And finally, this global community is now open to all of you. So feel free to have a look through the cases. And if you find anything that you want Imran to have a look at, during the next webinar, just at Imran in the reply section, at Imran Lasker. So just reply here and just at Imran Lasker, and he'll be able to see that, and he'll be able to use it in his next webinar. So yeah, thanks again, everyone, and hopefully see you on the next one.